Hello and welcome back to the Conquering Your Fibromyalgia podcast. I'm your host, Dr. Michael Lenz, a pediatrician, internist, and lifestyle medicine physician, here to help you navigate chronic pain and complex health issues by drawing on the latest clinical science with an evidence-based approach. Before we dive into today's critical topic, if you find this information valuable, please hit that subscribe button. Right now, most of you listening are not subscribed. By subscribing, you ensure you won't miss any new insights that could profoundly impact your health or the health of your loved ones. Today, we are moving past the assumption that chronic bedtime struggles are simply willful behavior. Instead, we are looking at a medical condition that could be the true hidden driver: Restless Leg Syndrome. We are drawing insights from a study entitled Rethinking Bedtime Resistance in Children with Autism. Is restless leg syndrome to blame? Are you caught in a nightly struggle where your child is restless, constantly kicking their legs or fighting sleep well past lights out? You might feel like you've exhausted every behavioral remedy. But what if those persistent movements are actually a nonverbal plea signifying a distinct, highly treatable sleep-related medical condition? Stay with us to learn why nearly 40% of children in one study dealing with chronic sleeplessness were found to have restless leg syndrome, a prevalence drastically higher than the general pediatric rate of 1 to 2%. Imagine realizing that the key to resolving your child's lifelong sleep problem might involve correcting a problem with dopamine in the brain or simply addressing iron stores. We'll explain the genetic and neurologic basis behind RLS, including a strong link to conditions like ADHD and autism, and reveal how treatments, including a commonly prescribed off-label medication that helped 100% of patients treated in this study, and can offer hope where traditional behavioral interventions have failed. Why is it so difficult to identify the true cause of chronic sleeplessness in children? Sleep disturbances, including bedtime resistance and prolonged time getting to bed, also known as prolonged sleep onset latency, are incredibly prevalent, affecting up to 80% of children with autism spectrum disorder. Caregivers describe sleepless nights featuring waves of motor restlessness and unsettled sleep. Identifying the actual drivers of sleep disruption can be challenging because the cause is often described as elusive, multifactorial, and notoriously difficult to treat. Clinicians often assume the bedtime resistance and motor restlessness are simply behavioral manifestations of the child's existing condition, leading to missed diagnostic opportunities for a separate medical problem. In the retrospective chart review detailed in this study of 103 children with autism and chronic insomnia, the prevalence of RLS found in this specific group was 39%. This finding suggests that RLS may be under-recognized. What exactly is RLS, and what is the genetic and neurologic cause? RLS is a highly heritable condition, meaning it tends to run strongly in families. In fact, one study found the prevalence of RLS among adult biological caregivers of children with autism was 22%, which is significantly higher than community estimates. The underlying problem or pathophysiology is linked to decreased iron storage and dopaminergic dysfunction. That means there is a problem with a chemical messenger called dopamine in certain parts of the brain. Since dopamine is essential for regulating movement, this dysfunction contributes significantly to the restlessness. It is not surprising that issues with dopamine are involved, as RLS and attention deficit hyperactivity disorder are highly associated with dopamine functioning. Prior studies have shown that the rate of RLS in children with ADHD can be as high as 44%. The general clinical association strengthens the argument for this shared neurologic foundation. The hallmark of RLS is an overwhelming urge to move the legs when at rest. This is usually accompanied by discomfort or pain and is relieved by movement. Crucially, the symptoms are characterized by nighttime circadian predominance, meaning they are worse in the evening when the child should be settling down. If a child cannot talk about an urge to move, what are the specific physical clues parents should look for at night? RLS frequently goes unrecognized in young children or those with language impairment because diagnosing it relies on the patient's ability to communicate that internal discomfort. Therefore, clinicians must heavily rely on the caregiver report and look for nonverbal expressions of discomfort. A caregiver endorsement of a nocturnal motor complaint was found to be a key factor in diagnosis. Specific motor behaviors found to be highly correlated with an RLS diagnosis included the following: leg kicking, body rocking, the presence of any symptoms involving the legs. In the study, 100% of RLS patients had a nocturnal motor complaint compared to 56% of the non-RLS group. It's vital for parents and clinicians to differentiate these movements from daytime motor mannerisms by specifically probing for motor behaviors that cluster in an evening circadian rhythm, as this is the classic signaling for RLS. How do we treat this, and why isn't iron always the answer? The initial treatment approach for RLS is to assess iron status using a full iron panel including serum ferritin and serum iron levels. RLS patients in this study had lower iron levels compared to non-RLS groups. Low ferritin was defined as less than 50 nanograms per milliliter. For RLS patients with low iron, the recommended treatment is oral iron supplementation. The treatment goal is to achieve a serum ferritin level of 50 nanograms per milliliter or higher. This benefit resulted in a significant clinical benefit in 92% of the patients treated solely with iron therapy who had also iron deficiency. Follow-up ferritin level values showed a significant improvement after iron supplementation. However, RLS is a highly heritable neurologic disorder. Not every patient is successfully treated with iron alone. Some patients have RLS with normal ferritin levels, or their symptoms may persist after iron supplementation. This is strongly suspected if there's a strong family history of restless leg. For these patients, clinicians gave gabapentin at bedtime. Although gabapentin is not U.S. FDA approved for treatment of RLS in children, it is commonly prescribed off-label for RLS and other conditions, and it's been approved in adults. The treatment outcomes were highly successful, with 100% of those patients treated with gabapentin reporting a positive clinical response, which is improvement or resolution of their initial sleep complaint, as well as feeling more rested in the morning. And gabapentin was generally well tolerated. These successful treatment outcomes highlight the importance of screening for RLS symptoms when chronic sleep disturbances exist. Current guidelines often focus on behavioral interventions or supplements like melatonin, but the researchers believe they may not sufficiently ring the alarm about the possibility of RLS as a potential cause of chronic insomnia. The key takeaway is that those difficult, restless nights may not be intentional misbehavior. They could be a treatable physical discomfort. If you recognize persistent nocturnal motor behaviors, especially leg kicking or body rocking, please talk to your doctor about screening for RLS and requesting a check of your child's iron status. Also look for other family members who may have restless leg syndrome. I'm Dr. Michael Lenz, a host of the Conquering Your Fibromyalgia podcast. If you found this information helpful, please share it. And if you haven't already, subscribe to keep up to date with new content and ensure you don't miss out on our next deep dive into conquering chronic health conditions.